on the recording. Welcome to our virtual empowerment symposium series. This program will discuss medical cannabis. We created this program because we want to give you, no matter where you are in the world, the opportunity to hear the best information on quality of life issues from professionals in our community. We are grateful to the Chu and Chan Foundation for making these webinars possible. If you have any questions during the presentation, please type them in the Q&A box, which you can see on your screen. We will leave time at the end to answer any questions. We are thrilled to have Dr. Jordan Tishler with us tonight. And trying to get my, sorry. Tishler with us for tonight. Dr. Tishler is a cannabis specialist. Through his training in internal medicine and years of practice as an emergency physician, Dr. Tishler brings his knowledge, reason, and caring to patients at Inhale MD, and through his advocacy work at the local and national levels. Dr. Tishler graduated from both Harvard College and Harvard Medical School, and trained at Brigham and Women's Hospital, and is a faculty at both the Brigham and Women's Hospital and Harvard Medical School. He has spent many years working with the underserved, particularly providing care for veterans. Having treated countless patients harmed by alcohol and drugs, his observation that he had never seen a cannabis overdose led Dr. Tishler to delve deeply into the science of cannabis safety and treatment. Dr. Cannabis is a frequent speaker and author on a variety of topics related to the medical application of cannabis. He is the president of the Association of Cannabis Specialists, which aims to educate clinicians, lawmakers, and the industry about best practices and needed tools for proper patient care. Dr. Tishler, please begin.
Hi, everybody. Thank you for coming. If you can click that button one more time, Susan, thank you. I want to just elaborate briefly on what Susan has told you about my background, all in the service of having you understand a little bit about where I'm coming from. As mentioned, yes, I went to Harvard Medical School and trained at a Harvard hospital in internal medicine. If you manage to get through Harvard 3 times, they call you Preparation H. And that I went from my training, ironically, in primary care to never practicing primary care. I went to do emergency medicine, and I did that for about 20 some odd years. The last 15 years or so, I did this for the VA. And at the VA, we take care of a lot of veterans whose lives have been dramatically affected by various substances. The top 10 list, 1 through 9, would be alcohol. And as mentioned, it was really when my state, which is Massachusetts, decided that we would consider cannabis as a potential medicine, that I had that aha moment and said, you know, I've seen so many patients who've been really harmed by various substances and yet not so much by cannabis, that maybe I should learn something about this. And so I did my homework, and took a few years, and I really kind of learned what was out there in terms of the science, and we're going to talk a lot about that this evening. That led me to realizing that I was one of fairly few who knew this material. As you can imagine, the VA was not ready to let me practice this kind of medicine, and unfortunately still is not. So I formed Inhale MD, which is a private practice. I have a couple of offices, and we do online medicine, and we do home visits and all of those sorts of things in the service of making sure that patients get what they need. But most importantly, I think, was to interface with my colleagues at these major medical centers so that we can really get in and work as a team with people's regular providers. I apologize, my cat is in the background. He's a rather chatty animal, and we'll just try to ignore him. And then, as mentioned, I started the Association of Cannabis Specialists really as a way to make sure that more and more clinicians would understand this medicine and be able to practice it and respect it and provide the kind of care for people that they need. And then as an outgrowth of that, we started realizing that we needed to advocate to the lawmakers to help them understand that that patients are often not well represented by industry's concerns, and to work with the industry to help them understand that patients have special needs and that they can't be viewed just as another recreational user. Next slide, please. So let's start by talking about what cannabis can do. And in particular, we're focusing here at the moment on symptoms. Now, everybody's talking about pain control. It turns out that if you survey patients in the United States, pain is the #1 complaint that they come to their doctors with. And also the #1 complaint where they report to their doctors that frankly, we aren't doing as well as we might like. And if you think about this, it's an unfortunate reality that there aren't a lot of options. There are really only 3 sort of categories of options, right? I mean, there's Tylenol, we all know and maybe love, which lives in a category by itself. And for certain things and certain people, Tylenol can be reasonably effective. But for some people, it's not effective. And for some people, there are reasons why they can't take it. Similarly, the other class, which are the non-steroidal anti-inflammatories, which contain things like Motrin, Advil, and a whole bunch of other cousins, all of which are more or less sort of the same, can be very effective, but they have even more side effects. They can affect your stomach, they can affect your kidneys, and for some people, therefore, they are not safe. And again, for some people, they're simply not enough. And if there are reasons why you can't take either of those first 2 groups, or they're not working, then the only remaining option at this point are opioids. Now, opioids have been getting a very bad rap of late, and I think perhaps that is a sign of the pendulum swinging too far. The reality here is that opioids definitely have their place, and we've certainly seen a lot of political machinations around that have gone way too far. But nonetheless, there is reality to the fact that #1, the opioids aren't super great at what they're doing. And #2, that they come with a lot of baggage in terms of side effects and risks. If we bring cannabis into this conversation, we have now enlarged the opportunities for treatment by a significant amount. And when we compare cannabis versus, say, the opioids, what we realize is that while neither of them are entirely brilliant for the treatment that we're looking for, the cannabis is about as effective as opioids for long-term chronic pain of the sort of moderate variety, and cannabis comes with significantly fewer risks. So if you ask me as a clinician how to approach using 2 substances, both of which are sort of equally effective, but one of them is a lot safer than the other, I think I would choose the safer one first. So what we know in addition to that is that cannabis, it's not an either-or proposition. Cannabis can be used with opioids, and you get a synergy of sorts in terms of the pain relief. And furthermore, in certain studies, we've shown that patients have reduced their use of opioids anywhere between 40 and 80% based on the introduction of cannabis into their regimen. As we know, the risks associated with opioid use are directly proportional to the amount that you're taking, meaning the more you take, the higher the risk. So any amount that we can reduce is of great benefit to the patient. So that's kind of pain in a nutshell. The next thing that goes along with pain is anxiety and depression. It's interesting that there are studies that try to sort of address these things as though they were separate. And perhaps there is some argument in favor of that, but I think we all recognize that anxiety and depression often go hand in hand with pain, either as a result of the pain or perhaps simply exacerbating and amplifying pain. What we know about cannabis and anxiety and depression, pardon me, is that it's a little bit of a mixed bag. If you look at the literature, you'll find that there are some studies that show that cannabis can be helpful, and there are other studies that show that cannabis can be counterproductive. But when you dig into that literature, what you realize is that a lot of the problems with this science is that you, because of the way the laws are at the moment, can't really describe or even control the amount and type of cannabis that is being used by the patients who are participating in the study. To the extent that we've been able to tease this apart, what we've learned is that it's all about the dose, and that a little can be helpful, but a lot can be counterproductive. What we know about depression in particular is that cannabis can be helpful at low dose for depression. It tends to be, what I was looking for? A fairly weak antidepressant. So when patients come to me and they say, I'm on a little bit of an antidepressant such as Zoloft, and I'd like to get off that and use cannabis instead, that may be a reasonable approach. But if somebody comes in and they're on a higher than starting dose of that SSRI, then generally speaking, cannabis is not a good substitute. On the other hand, it's not really, again, an either or proposition, because cannabis can be helpful in addition to the SSRI. And as we know, many of the antidepressants come with some side effects. For example, feeling of blunted mood, or people say, I feel like a zombie, or issues around sexuality. And what we've learned is that by adding cannabis to the SSRI, we can actually undo some of those side effects, and so you get that synergy. When it comes to anxiety, cannabis can be very effective, but it's very important not only the dosing, but the timing. If you ask many cannabis users who come from a more recreational background, they will tell you that the way to use cannabis for anxiety is to get up in the morning and immediately start using cannabis and use it throughout the day. And nothing could be further from the right way. In fact, we can give small doses of cannabis around bedtime so that the cannabis's major effect and side effect of intoxication wears off during sleep, and yet the benefit for anxiety control persists for the next 24 hours. And so we know that it is not necessary to use it during the day, and it is not necessary to be intoxicated during the daytime for the treatment of anxiety. Next click, please. If you ask me, the thing that cannabis treats best of all is insomnia, even better than pain. There are several different types of insomnia, and how we approach insomnia with cannabis depends on what sort of insomnia we're talking about, but ultimately a low dose of cannabis around bedtime seems to work very well for the treatment of insomnia, with fewer side effects than many of the conventional medications that we have, which, as we all know, are not super effective. Next click, please. Anorexia, in this case, does not mean anorexia nervosa, which I imagine many people thought of when they saw the word, but rather it's simply the medical term for difficulty eating. That's certainly a problem we see with patients who are getting chemotherapy, but is also an issue for other people with chronic illnesses like Marfan syndrome. Cannabis can be used very effectively. Again, the dosing and the timing is of crucial importance, but this is an area where we can make significant mileage. Next click. Nausea and vomiting, probably not significantly relevant here, but certainly an issue for those who are getting chemotherapy, and has been shown to be very effective in head-to-head trials with the major anti-nausea medicines that we have. Next click. And sexual dysfunction, this is probably a larger area, but it's also an area where I could spend an entire hour speaking, but let us just touch on it very briefly to say that there aren't a whole lot of medicines in the conventional armamentarium for the treatment of sexual dysfunction. We certainly know about the medications that are available for erectile dysfunction in men, but they don't do anything for women. And certainly there are sexual issues for men that are not simply erectile dysfunction. And what's interesting is that cannabis, when used in a careful and dose-specific manner, can be very effective for both men and women across a range of sexual issues, from low desire to difficulty with arousal, to difficulty achieving satisfying orgasms, and also will promote the sense of intimacy that is actually, interestingly enough, rather hormonally controlled in the post-orgasmic state. I think I will leave that subject there, but we certainly could spend some more time on it. Next click. Actually, let's just skip over this slide entirely because I don't think it's all that relevant to us tonight. Now, before we go too much further, let's address the elephant that's in the room, because quite frankly, I think after 70+ years of being told that cannabis is a no-no, we need to really talk about what we know about its potential harms. And so the first thing I think that everybody wants to ask is, well, isn't it addictive, and aren't I gonna get into trouble with this stuff? And there's a couple of factors here that we really need to kind of keep in mind. And the first is the second line down, which is dependence is not the same as addiction. Dependence is a physiologic response when your body gets used to a certain substance, particularly if that substance is actually helpful to you. Then if you remove that substance, your body gets annoyed with you and lets you know. And that's what we talk about called withdrawal. And to be sure, that's an important thing for us to discuss, and we'll come back to that in a second. Addiction, on the other hand, is really a set of maladaptive behaviors that arise around the use of a particular substance. And so what I tend to think of are things like spousal abuse, or knocking over liquor stores to get money for your fix, and those sorts of things. And simply, we do not see that sort of behavior in cannabis users at all. Let us look a little bit at the risks then. So the lifetime risk of dependence, and again, this is dependence, not addiction, for cannabis is actually a little lower than what's on the slide in front of you. The most recent numbers look like about 7%. If we compare that against other substances that we know well, for example, nicotine at 32%, opioids at sort of 23 to 25%, cocaine's about 17%, benzodiazepines, which are not on this list, are also about 17, 18%, and good old alcohol is at about 15%. You start to realize that cannabis is pretty significantly safer than any of those things. The other thing that's interesting about this, these statistics are that the risks for all of the things on that list that are not cannabis are a constant, meaning if you pick up opioid use when you are 17 or 47 or 67, your risk is still around that same 25%. But for cannabis, it turns out your risk is front-loaded. So if you're a teenager, your risk from cannabis use is actually closer to that 17 to 18%. On the other hand, if you've made it to the ripe old age of 25, your risk drops to about 2 to 3%. So now we've kind of talked about what is the likelihood of some sort of a problem, but what we really haven't addressed yet is sort of how bad is this problem should it actually come up. So we're saying it's not very common, but let's talk about what it is. And I think that due to Hollywood, I think we've all got an image in our head of withdrawal, of, you know, a guy strung out on the floor, probably buck naked, sweating, vomiting, screaming at the top of his lungs. And certainly that image is accurate if a worst case scenario for opioid withdrawal, but has absolutely nothing to do with withdrawal from cannabis. In fact, cannabis withdrawal tends to be somewhere between 3 and 7 days of crankiness and difficulty sleeping. So the risk is not only less likely, but if it were to happen, those consequences are not horrible. Next slide, please. And now we can talk a little bit about how you do this sort of thing. And the thing that's very interesting to me is not only is the dose super important, but the way we use it is super important. And there are a bunch of biological reasons for that we'll talk about as we go. The first on this list, obviously, is smoking. And you can be sure that as a physician, I don't recommend that anybody smoke cannabis, at least on any long-term basis. The interesting tidbit is that we have studied cannabis smokers for, it's roughly 30 years at this point. And what we have found is that unlike tobacco smoke, people don't seem to get emphysema or lung cancer. And I think it's reasonable then to ask the question, well, why not? And I don't think we have any idea. And so that leaves us feeling a little bit uncomfortable, and also recognizing that 30 years is a very long study in the history of science, but that the people who smoke tobacco tend to get sick at 40 plus years. So 30 years is reassuring, but I don't think that we have the end of that discussion. But smoking is really one form of inhalation. And if we think of inhalation as a method, we recognize that it has certain characteristics that in certain circumstances may be beneficial. Inhalation is fairly rapid onset, meaning within 10 to 15 minutes, it's really doing its job. It's also fairly modest in its duration, meaning, again, it works for about 3 or 4 hours and then it starts to wear off. So that set of behaviors is very helpful for problems that are acute or episodic. And I often use the example of a migraine headache, where you want the medicine to get in there really quickly and do its job and to sort of nip it in the bud. But then if the headache goes away, you'd like the medicine to go away so you can get on with things. So that would be an example, again, of when I would turn to inhalation. Now, inhalation, if we're not using smoking, means vaporization. Vaporization has gotten quite a lot of bad press lately, and it's important for us to understand, excuse me, that not all vaporization is the same. So if you look in the middle of the slide, you'll see that there's this little pen-shaped object that has an amber-colored or orange-colored oil cartridge at the top of that. And those are the things that I would never recommend, and which have now been shown to be causing some acute illness in a large number of people. The problem with these devices is manyfold. The first, the thing that's creating the problem right now, is that a lot of these devices have stuff put in that cannabis in the oil that goes in the cartridge that turns out to be unsafe. That unfortunately was a bit predictable, and we're now reaping the rewards, so to speak, of not having predicted that. Clearly, we can fix that problem. The other problem is that these devices are very, very simple. As you can see, it's a cartridge that has a little heating element, and in that handle is a battery and a little switch that responds to your the pressure of your inhaling on it. And that's pretty much it. So the problem is that those devices do not control temperature in any fashion. And even the devices out there that pretend to control temperature are only estimating that temperature and are not actually appropriately measuring the temperature at the heating source. And the result of that is that while they're being called vaporizer pens, they're really combustion pens. So we're sucking on these things thinking that we're doing a good thing, but we're really getting a lung full of toxins that we're really ought to be avoiding. So again, I would not recommend those sorts of things at all. Immediately above the pen on the page is this thing with all the fins. And that is the machine, or that is a type of the machine that I would in fact recommend. That is a flower vaporizer. Now, when I say flower, I mean flower like a rose. And I mean this because the part of the cannabis plant that we actually use is the bud or the flower of the plant. So we try to be anatomically correct about human beings, and in this case, we're trying to be anatomically correct about the plant. So when we purchase the cannabis flower, grind it up, we can put it inside that machine. The top comes off, and there's a little bowl in there, and you fill that up with the ground cannabis material. And the thing that's good about these machines is that they have a little microprocessor controlled thermostat. So they're actually measuring the temperature at the heating point where the cannabis is and using that to control the temperature. So when we set that temperature to the correct temperature, which by the way is 350 degrees Fahrenheit, I always say just like we were making cookies, right? That machine is capable of getting to that temperature and staying at that temperature. And at 350 degrees, now when we get the vapor, we are simply getting the medicines and we are not getting any products of combustion. The products of combustion start to be made at around 400 degrees, so we want to avoid 400 degrees. And again, you can see that that's a fairly narrow range between 350 and 400, which means that a sophisticated device is in fact necessary. Now, so that was a long spiel on inhalation. Taking the medicine by mouth is a very different proposition, where the inhaled stuff is quick and relatively short acting. Taking it by mouth is a bit slower to work, typically around an hour, but it can be fairly variable and a little bit unpredictable, which makes it harder to work with. But the advantage is that once it starts to work, it works for much longer, sort of typically between 8 and 12 hours. So while the inhaled stuff is kind of our immediate treatment, the oral stuff is really our extended release treatment. And you can see on the left of the screen, we've got that little cookie there with the balls of cannabis flower. I'd forgotten there's an example of cannabis flower. I don't recommend cookies. I think that the idea of a cannabis edible that is part of some sort of junk food is not necessarily in our to our advantage, and that we have to, as we try to be holistic about our approach to patient care, remember that people are certainly more than just their need for cannabis, and many of our patients are overweight or perhaps diabetic, and we don't want to make life harder for them by proposing an extra 250 calorie brownie twice a day. So there are much better edible types out there. My favored type is a very small little gummy, sort of like a gummy vitamin type thing. which typically contains about 5 milligrams of cannabis THC component. And this can be very, very effective. This is, because of the delayed onset and the prolonged duration, this is what I tend to think of when we're talking about somebody who has continuous sort of 24/7 pain, for example. And certainly that would be relevant for lots of people in the Marfan's community. There are obviously times when we might need some of both of these modalities, and that would be something we'd want to think about how to use together. There are a few other approaches that are out there. Tincture, which is this liquidy stuff here in the blue vial on the left, which is basically a liquid extract of cannabis. I don't use them super often, and the reason is this. If you listen to the people on the internet or the cannabis aficionados, they will talk about tinctures as being absorbed under your tongue. And there are some tinctures that can be absorbed under the tongue, but they are pharmaceutical in nature. So if you're getting your tincture from a dispensary, those do not work that way. And so the whole holding it under your tongue thing is the kind of infuriating BS that I like to avoid. And what really happens, of course, is that you swallow that oil and it is absorbed in your gut as would anything else. But because they are oils, the absorption is actually pretty lousy. In fact, all gut absorption of cannabis is pretty lousy, but the tinctures are about half, only half as much gets absorbed compared with, say, a properly made edible. So there are times when I will use a tincture if I need to use a very, very low dose, or if somebody, for example, has a feeding tube, then a cannabis tincture can in fact be helpful. But generally speaking, again, in comparing it with, say, that little gummy, the gummy is generally more effective and certainly easier to use. Cannabis topicals are hotly contested, but the data that we have shows that they may in fact be good for skin conditions, but in fact the cannabinoids do not penetrate through the skin. And so the idea that one might rub a cream on your knee because you have arthritis in the knee joint just doesn't work out. Which is to say that around 40% of people who rub goop of any sort on their knee for their arthritis will feel better, but that is in fact the placebo effect. And you pay a ton of money for these little pots of the cannabis cream, sort of $80 for that little tiny thing that you're looking at there, versus, you could pay $5 for some Lubriderm at the drugstore and get a gallon of it. So if they're going to work about equally effectively, I'm in favor of skipping the really expensive cannabis stuff in that situation. All right, I think we've gone here. All right, perfect. So the dose is really crucial. And if we look at this little graph at the top, what we need to understand is this, that for all medicines, and this is certainly not specific to cannabis, there is a graph that looks like this. So you start off down at the 0 point and you kind of climb up that hill as you increase the dose up to the point where you're at that peak where the sweet spot is. And that's where you're getting the best benefit with the least side effects. But if you go over the hill there, what you find is that more is not better. That once you are past the point of maximal benefit, all you're doing by adding increased dose is adding more side effects. We should talk a little bit about what those side effects really are. Primarily, the cannabis side effects are intoxication, right? I mean, the getting high. And certainly there are people out there who very much enjoy that process. And even for the people who are not seeking that, it's often more pleasant than they anticipate. But in any case, is generally unwanted. At least it's not the primary purpose of taking this medication. The good news is if we get ourselves to that sweet spot, then that's the place at which we get the best benefit with the minimum of those side effects. The other side effects that are worth mentioning, which are, though they are certainly less intrusive, are things like dry mouth, and in rare occasions we can see some racing heart and that sort of thing. But generally speaking, those are reasonably well dealt with simply, again, by getting the dose right and also having some water on hand. So in general, my patients are doing remarkably well with cannabis medicine in this 10 to 15 milligram range. That's a very low dose. It's much lower than most people who use this stuff recreationally are using, but it isn't necessary to go above this. And I think the most important thing is to suggest that what we're not doing is sending people home to do bong rips like you can see in the picture at the right. Yes, good, thank you. Hit the button a couple more times. That's perfect. So many people want, come to me and they want to know about various types of cannabis, which are called strains. And there are, in fact, over 7,000 different strains. What's interesting to me about all of these different types is that when my patients use these medications, most of the time, I would say between 85 and 90% of them tell me that they cannot tell the difference between these strains. Moreover, nearly 100% of my patients tell me that they, regardless of the strain, they are getting the medical benefit. And so I think what's very important is to understand the difference between the medical outcome, right? Is my pain better, versus essentially preference, which is I prefer this strain over that strain. Both of them take care of my pain just fine, but I have a slightly better experience on this one versus that one. Ultimately, I think that the cannabis industry stands to gain the most by presenting the idea that strains are unique and different from one another, because ultimately that leads people on a quest essentially for the holy grail of strains. What will be best for me? But in reality, what I see is it doesn't seem to make a lot of difference to their medical outcomes. The other thing that people are talking about in droves at the moment is CBD. CBD stands for cannabidiol, and it is a cannabis medicine or cannabinoid from cannabis that right now is very in, shall we say. And I think that a large portion of the reason it's become so hip is because it doesn't cause any intoxication. On the other hand, it's not clear that it does a whole lot of anything else at the doses that people are getting. So in the laboratory, when we're talking about either a test tube full of human cells or a cage full of mice, we can give CBD and get some anti-inflammatory benefit. We can get what appears to be in mice some anti-anxiety benefit. But these studies have really not been borne out particularly well in human beings just yet. It led me to ask the question, what percentage of medications that work for mice fail in human beings? And that turns out to be an astounding 92%. So this leads me to the conclusion that just because it works for mice is no reason to try it out in human beings until we've tried it, unless we've done some studies in human beings. At the same time, one of the things that has been interesting is that across the mouse studies, the few adult human studies, and the more significant child epilepsy studies, what we find is the dosing of CBD is actually remarkably consistent, which is to say that you need between 10 and 20 milligrams per kilogram of body weight in order for it to really be doing anything. So if an average human being is somewhere around 70 kilos, we're talking about 700 to 1400 milligrams of CBD per day. I don't know anybody who's getting that because it's prohibitively expensive. If you were able to get that kind of dose, however, then we need to worry about drug interactions, because in fact, CBD, more than any other component of cannabis, can interact with many conventional medications. So this includes things like blood thinners like Plavix and warfarin, heart medications like amiodarone, statins, so that the list goes on and on. We're not at present seeing a lot of these interactions, largely because nobody's taking a high enough dose of CBD to be getting those interactions, but also not enough to be getting any significant physiologic benefit. And the last negative thing, unfortunately, I'm forced to say about CBD is that CBD right now is not regulated at the federal level. Right? We all know that CBD is now available for sale online and at the corner grocery store and in the corner gas station, but the FDA has not passed regulations on this, which means that when we have studied the stuff that you can get in those locations, what we have found is that the good news is that many times there's no CBD in it at all. And the bad news is that it may contain other things that are toxic, like pesticides and heavy metals, or even worse, things like benzos and opioids. So at the moment, I think it's probably pretty risky to purchase CBD in that sort of over-the-counter or online fashion. If you could click a couple more times. That's perfect. You know, when you hear people talking about medical cannabis programs, there's a very odd, to me, strong emphasis on sort of getting your card, or worse yet, people talk about getting their license. And I'm thinking to myself, what are you talking about license? It's not like you're a dog and getting your, you know, your dog tags here. What we're really looking for is safe and effective medical care. And, you know, I would liken this to if you were going to your doctor because you thought that you have high blood pressure, you, generally speaking, wouldn't go in and say, "Doc, give me this medicine, give me lisinopril." You would go in and you'd say, "Doc, I'm concerned I might be ill. What do you think is going on and how should we treat it?" And I think that's a much better model for the approach to cannabis medicine, just like any other kind of medicine. We don't want to emphasize getting your card. We want to emphasize getting an appropriate care and an appropriate treatment plan. And part of the reason for that is that, you know, in the sort of loosey-goosey model that we inherited from California, the physician oftentimes was not providing the kind of guidance that she or he ought to be. And I think we're working hard now to change that. And a result of that was that dispensaries took upon themselves to provide information to patients. And the problem is the people at the dispensaries are trained about as well as your average Starbucks barista. So I often say to my patients, if you wouldn't ask at Starbucks about your healthcare, you probably shouldn't ask at the dispensary either. And the dispensaries, of course, sell the products. And so there is a conflict of interest there. And often they give a lot of misinformation in an attempt, well, maybe attempt is too strong, but because of their lack of education and scientific knowledge, they provide misinformation that then leads to patients purchasing more than they need and often the wrong kinds of product. And I see this many times a week, unfortunately, and it unfortunately is still a problem even after I have spent an hour with the patient describing exactly what we're talking about today, as well as giving them written instructions as to what to purchase and how to use it. So there is a little bit of the sort of who had the patient's ear last. So we need to regard the folks at the dispensaries as well-intentioned, but oftentimes slightly prone to taking us in the wrong direction. And as a result, I think it's incumbent on physicians to provide the kind of care that we expect, and really to make sure that we have close follow-up and very clear medical guidance and access to the clinician, so that when things come up or the dispensary makes changes, or even the regimen needs to be adjusted, all of those things can be handled in a transparent and easy fashion. Next slide, please. Click a bunch of times here to get all the stuff up on the screen. There we go. Just a quick plug for the Association of Cannabis Specialists. Our goal is really to get those clinicians familiar with what we're talking about this evening, and to make sure that they're ready and available to provide the kind of care that we've talked about. So we want to increase that standard of care for patients, meaning they get the proper advice from the properly educated clinician. We want to make sure that clinicians or physicians who are not going to be doing this kind of medicine, say your PCP, also know enough about this so they know when cannabis medicine would be appropriate, that they understand that it is in fact a valid medicine, and they can refer appropriately to a specialist. We want to work with dispensaries so that they understand, again, that patients have special needs that are not just another kind of recreational user. And quite frankly, as we talked about earlier, about not having, brownies and cookies as the edibles of choice, but really making sure that we have the appropriate low caloric density, low dose products that allow us to treat people and get the best results and hit that sweet spot. We obviously want to encourage further research, and most important, well, not most important, but equally important, is to work with lawmakers to improve the regulations so that clinicians have the tools that they need in order to provide the care that we've just been talking about. So if you guys have the chance to visit the website, which is cannabis-specialist.org, you'll find a wealth of information there. You'll also find a directory that will help you find specialists in your neck of the woods who can help you. Next slide, please. Yep, one more tap. And this provides some scientific studies for you if you were interested in reading them, but it also provides how to reach me if you are interested in further consultation. We can do things, as I said, by telemedicine if you're not in the area, which is Massachusetts, or if you are in Massachusetts but are having difficulty making it out of the house, we can arrange a home visit. And that pretty much is what I wanted to say to you all this evening. I appreciate your hanging in there with me, and now I'd be happy to answer questions.
Okay, before we go on to questions, thank you so much, Dr. Tishler. I just wanted to just give a plug about our Pact Health program. I don't know if everybody here knows about it. It's an app that's very easy to get onto your phone. It's safe, secure. It comes in 6 languages and has functionality that allows you to share certain information with others in your circle as you wish, whether it is your school nurse or your grandparents who are taking the kids on vacation, a new doctor, or anybody even in an emergency situation. This year we have a new campaign. We are trying to get 2,220 people to join in the year 2020. So right now we're up to 1188. Please join us. Go onto your phone, onto your apps, or you can also download it on your computer. And there is information on our website and on these apps to help you load your information. And these are just some other things. Okay, let's see what we got for questions. Okay, so first question is, can we use CBD/THC as an oil or as an edible while on blood thinners?
Um, So the fact that it's in an oil form is not really relevant to whether it's okay with blood thinners. The chemicals, the THC and CBD are, the THC is fine and the CBD is generally not so fine. So in this case, if somebody were on a blood thinner, this is a time that I would recommend avoiding CBD and sticking primarily with a THC dominant approach.
Next question is, can you explain the different strains, Indica versus Sativa, and when they might be useful?
Yes. So remember I was saying that there are thousands of these different strains and they get lumped into these categories of indica versus sativa, and then there are hybrids that are sort of in between. And the idea of these categories is to sort of assign what the strain is likely to do to you or for you, I suppose. The ideas that are put forward are that sativa strains are supposed to make you peppy and make you full of energy. And the indica strains are supposed to make you sort of sleepy and contented. But the reality here is that what we know is that that whole concept is completely wrong. And again, it's terminology that has arisen from our friends in the recreational areas based on their experience. But when we have studied these different strains and the chemicals, what we found is that the overlap between an indica strain and a sativa strain is so much that this this nomenclature, this way of dividing things up, just doesn't make any sense at all. There is truth to the fact that certain strains have more or less of certain components and may ultimately turn out to be more useful for something than another one. But at the moment, the research is not there to, to prove or even to point in that direction. So that's why I was saying earlier that in fact, it doesn't seem to matter much what strain or whether it's indica versus sativa. One thing I will add is that, as you all probably know, the recreational users have for years created a market for higher and higher THC strains. And so many strains at this point are 25 or 30 or even 35% THC. These are strains that I would not recommend. And the reason is this: what we know is that pure THC is not very effective because, in fact, we've had THC in a pill since the early 1990s called Marinol. And in fact, Marinol just isn't very effective because the THC causes that intoxication side effect so briskly that we don't even reach a therapeutic level before it's intolerable to the patient. So most people will take Marinol a few times and then say, forget it, it isn't helping and it's making me feel lousy. And what we've learned subsequently is this idea of what's called the entourage effect. And really what this says is that the THC, generally speaking, is really the main medicine, but it doesn't do the work by itself. It needs this other group of chemicals that I call the helper chemicals. And that includes some CBD, but it also includes a whole bunch of other things. Now, if you have a strain which by percentage of weight has increasing THC levels, that means the levels of all those helper chemicals must be going down. And at some point, the level of the helper chemicals goes down enough that this strain is really not very effective for the symptom management that we're talking about. And it will, of course, cause more of that intoxication side effect. So typically, we would recommend strains that are between 15 to 20% THC as a way of getting a better balance between the THC and all of those helpers. Again, it doesn't seem to matter what the particular strain is, and it doesn't seem to matter whether somebody called it an indica or a sativa.
Thank you. How risky is cannabis for patients that suffer from arrhythmia?
That's a complicated question. And I would say that, I would say this, there is some evidence that cannabis can provoke a particular arrhythmia called atrial fibrillation, which generally speaking is not particularly harmful to people, but it's something that needs to be noted and treated. And it can be treated in a number of ways. There are ways to make it go away that work sometimes. And if that doesn't work, then the treatment is a blood thinner. So if you have atrial fibrillation and it's gone away, then that's not something I'd be too worried about. If you have atrial fibrillation that won't go away and you're on a blood thinner, then that wouldn't be something I'd be too worried about, assuming that your heart is otherwise pumping normally. There are some people who have, decreased pump function, meaning their heart doesn't squeeze as well as it should, and who are very much more dependent upon their normal function of the atrium. In those people, that risk then is a little bit elevated because if we put them into atrial fibrillation, their overall heart function may decrease. So again, I think, or the answer then to your question really is, it depends a bit on the particulars of that individual. There are more significant arrhythmias, meaning more intrusive and or more dangerous arrhythmias, but in fact, those don't seem to be affected by cannabis. And in fact, in some studies, in patients who are already in the hospital because they just had a heart attack, it looks that actually the cannabis protects against arrhythmias that sometimes happen after a heart attack. What does that mean to us as general cannabis patients? I don't know. But I think the point is more research needs to be done on that, and we're not seeing a lot of risk associated with use of cannabis provoking cardiac arrhythmias. I hope that answers the question.
That's great, thank you. Can you use CBD gummies while taking losartan potassium?
Yes, there's no interaction there. So yes, there's no problem with those two together. I would just, again, question what's the value of taking the CBD gummy, and also what is the risk based on, where those gummies came from.
Okay. Is it the CBD that is considered to have possible interaction with other medications?
Yes. I mean, all of the cannabis components, THC and CBD and a bunch of other stuff, can have theoretical interactions, but in reality, it's the CBD that we have to worry about.
Is it therefore considered preferable to vaporize or smoke cannabis versus taking by mouth, digesting it when on other medications?
No, the likelihood of an interaction with another drug is not related to how you took it. It's just the chemistry of those two drugs.
Okay. Which would one or more routes of administration be preferable for those with Marfan or other connective tissue disorders?
Preferable in the sense of sort of interacting with the disease, no. But in terms of treating the symptoms of the disease, Yes. I mean, that is to say, in most of the patients that I have who have Marfans, they've got significant pain all the time. And in that situation, I would go back to the edible or oral route because of its sort of, extended release characteristics. So in those situations, I would typically be giving a cannabis edible twice a day, morning and evening, as a way to establish baseline pain control. And then if necessary, we can use some inhalation therapy for breakthrough pain.
So I think you did answer this one then about specific issues directly related to connective tissues disorders and what cannabis would help relieve. And you did say that mostly it would be for the pain.
Pain is certainly the number one issue. I think that people, again, often going hand in hand with pain is anxiety, particularly sometimes depression, very often insomnia. And so all of those things can be addressed using the cannabis as a medicine. The other thing that, I may be, well, never mind. I think I'll leave that there.
Okay. How much CBD would it take to have an effect on warfarin?
That's a reasonable question that I think we don't entirely know the answer to. And part of the reason we don't know the answer to that is that it's not strictly the CBD and the warfarin, but also your particular liver enzymes that will influence the answer to that. But I can tell you this, that we have seen we've seen interactions with warfarin specifically and other drugs as well at doses of CBD that are well below what we would expect necessary to get benefit. Meaning, again, if you're looking at the studies and you're thinking that somewhere between 300 and 700 milligrams might be necessary for benefit, what we've seen is that the interactions might start somewhere between 50 and 100 milligrams. And so, there's no getting to the benefit without creating the problems in that case.
I actually have a question. So are you saying that basically these CBD oils are ineffective and are not worth using? For instance, I know people who are using them on their knees on a regular basis, or their feet or their backs, and that it has more of a placebo effect than actually any real effect?
Unfortunately, that's exactly what I am saying. What I've been noted to say a lot is I think that right now, given the popularity of CBD, what we're really looking at here is the emperor's new clothes. I think that at the end of the day, when all the hype dies away, what we're going to find is that it is largely useless at the doses that people are presently taking, that it will turn out to have some very useful and specific value in very specific situations. So I think that it's very clear that it is a good anti-epileptic in children, but those children, number one, have some pretty rare genetic seizure disorders. It's not clear that this will generalize to children, to normal epileptic children. And it's not clear that it will be meaningful for adults either. And I think that it may turn out that it does in fact have some anti-anxiety benefit at those enormous doses. But at those enormous doses, we'll then have to grapple with how are we paying for this, because it's just not affordable as it stands at the moment. Now, we can either bring the price down by learning how to manufacture this in much greater volume, or we have to get insurance into the mix. But we're nowhere on either of those approaches just at the moment.
No, thank you. One last question. To try the gummy bears, how many days does one need to take it for the effects to be felt?
The effects should be felt immediately, but it's a little bit more complicated than that, which is to say that on day one, you're more likely to have more side effects and less benefit. And then, excuse me, over time, the side effects die down and the benefit is more noticeable. So I would typically start somebody on a dose that is significantly lower than where I think they're going to get benefit, because we don't want to overshoot and we don't want the side effects to be so pronounced that people are unwilling to proceed. And so if we give, say, a 5 milligram gummy as the starting point, first of all, if we think that we're going to ultimately use this twice a day, I wouldn't start that way. I would start just in the evening and do our figuring out in the evening. And again, as I said, if we're starting at 5 milligrams, that's probably low compared to where we will end up. But if we do this over the course of a week or two, it gives our body a chance to adjust to the medicine, as well as for us, psychologically or personally, to get used to the side effect and to realize that it isn't going to, undo us in any fashion. And then slowly we can then advance the dose to the point at which we find that sweet spot and get the benefit that we're looking for.
Yeah, thank you so much. I think that was all the questions. So I want to thank Dr. Tishler so much for his time tonight, and thank all of you for participating. We will be sending out a link very soon. If you'd like to review this again, it will be on our website also. I just want to point out some upcoming programs. We have our next 2 empowerment series, management of dissections and aneurysms in vascular Ehlers-Danlos, and dental concerns in Marfan and related conditions. You can sign up for any of these on our website. And you can also view all of our past recordings under patients and families, either virtual medical or empowerment webinar series. Next slide. Sorry. Oh, wait, there was another question. Oh, thank you. Everybody's saying thank you.
Well, thank you all for coming this evening and listening. Please do not feel shy about reaching out to me. I love to talk to people and would be most happy to be able to be of help to you. And I would like to thank Susan and the Marfan Syndrome for having me on this evening.
Thank you. It really, and you will also be at our conference this year. So for anybody who is interested, please let me know.
I'm looking forward to that.
Thank you.